Hey, as promised, a bit late, but still there. We're going to talk about the translatory subluxations, and we'll take a foray into the anterior one as well, because it's basically the same principle, so it won't hurt to deal with it. So let's share screen and go to the whiteboard and see what we got. So what we're talking about is, this is the two vertebra, disc sitting there, and this transverse process is like so. Now, we've been talking pretty much all this time about facet subluxations, which are occurring around there. So they'll sublux either into flexion or they'll sublux into extension. And we've seen the vertebra rotate when that happens. And this is because it's moving asymmetrically. So as one side moves more than the other one, the one that's moving less is more posterior, so it rotates and side bends towards that side. Now, this isn't coupling. Coupling is where the vertebra rotates and side bends as a conjunct movement, or side bends and rotates as a conjunct movement. These are normal. This is abnormal rotation, because the axis of movement has changed because of the hypermobility. This is occurring, as we say, at the not necessarily at the facet joint, but if it's an articular problem, it's occurring at the facet joint. So we're talking about this. So the vertebra has done that, like so, and gone that way. So it's translated across the centrum. The facets are accommodating this, they have to, otherwise they break. And at the same time, the vertebra is rotated. In this instance, it's rotated to the left, if we're looking at the back of these things, okay? Now, the rotation can either be modeled as the primary subluxation with the translation as the secondary, or the translation is the primary driver and the rotation is secondary to the translation. It really doesn't make much difference in the way you look at it. The fact is, if I try and push, if I try to derotate this by pushing on that transverse process of the P pivot, it won't derotate. The end field won't be what you expect from a facet joint, though. This will be abnormal, but not the same thing. It's not hard capsular, it's not jammed, it's just a sort of a weird sensation. I can't tell you. It's just abnormal compared to the other vertebra above and below it. Similarly, though, if I try to translate this back across the vertebra to replace it in its normal translation, then it gets jammed. And again, now the end field actually is more what you expect. It's a harder end field than when you try to derotate it. So as I say, it really doesn't matter too much which way you look at this, whether you look at it as a rotatory subluxation or a translatory subluxation. They'll both work. And really a good model is just to explain the observations and give you an intervention. So what you see clinically is basically a vertebra that is rotated consistently. In this case, we've got it rotating to the left on the one below it. And that is there. That posterior transverse process is felt in flexion, extension, and in neutral. Now, the problem with modeling this as a rotary subluxation, it means that the treatment has to be to derotate this. And there are rotational manipulations for the lumbar spine, but rotation is accepted as more stressful on the annulus than is any other movement. So the annulus is best at dealing with flexion, extension, side bending movements, but it doesn't do well with rotation. And in the lumbar spine, there are many mechanisms to stop rotation occurring. Everything from the orientation of the facets being sagittal to iliolumbar ligaments to L4-5 actually being wedge-shaped this way, or L5-S1 rather. So the sacrum's there, and L5 is actually a wedge shape, so it's wider at the front like so than it is at the back. So to go anterior and rotate anteriorly, it has to go uphill. So there are a number of mechanisms. It doesn't want to do this. And even in the rest of the spine, in the thorax, you have the head of the rib coming up and articulating with two vertebrae, and that will also resist rotation, even though now the facets are coronal. When in the cervical spine, with its coronal facets, we have unconvertible joints that do the same thing. The only levels where rotation is relatively permitted is at the AA joint, where there is no disc, and at T1112, where the facets are orientated coronally, and there is no head of the rib going up. It's the one above it. So this is this translatory one. So if you identify it initially by the P-pivot, so you come in, fill position, you fill the posterior transverse process, you pivot it, which is a PA. When that's positive, you then PAVM it, which is a supro-anterior glide. And as I say, you'll get an abnormal infill, but it's not an articular infill as we're used to feeling it. Treatments for this depends on your model. As I say, if you're modeling this as a rotary subluxation, then your treatment is going to be to derotate with manipulation. And as I say, basically these rotations are not good for the disc. And given that the articles on this suggest anywhere from 20 to 80% of people have an asymptomatic disc bulge, where the annulus is obviously friable. Maybe putting rotation through these things is not the best idea. So you can derotate it, or you can do the Mackenzie glide, where you basically pull over. So your shoulder goes into the hip that's jutting out, you grab around the body and pull the trunk towards you and push the hip the other way. So you basically de-translate it. And this isn't a manip, although you can sort of shake it while you're doing it, but it's more of a gradual thing, and often they'll go. You can also do traction. So you can imagine this sitting like that, in this way. So you lift it up and drop it down again, or you can drop the one below it down and allow it to come back, but you distract the joint between the two vertebral bodies, and then you hope that the thing resettles, as it were. Now, this is an effective technique. The problem in the lumbar spine is that it's a little dangerous, especially if there's a big disparity between your weights and your body and your heights. So I usually reserve teaching this until more advanced course, where you're used to doing manipulation, using your body better than you're probably using it now. I also don't allow in my classes pregnant women to use this one, because there's a fair amount of strain with it. You have to sort of lift them up and drop, and it's not an easy technique to do. Now, you see this probably more commonly. It's not rare in the lumbar spine, but it's probably more common in the upper thoracic spine. And you see this quite often there. And now traction is much more viable treatment. You can either do a lift traction, where you're lifting the top vertebra up, or allowing the bottom one to drop down. But that's a much more viable treatment, simply because you're not having to hold pretty much all of the body weight from about the upper chest downwards, where you're holding the arms across their body. As I say, in that case, you would model this as a translatory subluxation. So my order of doing this right now for you would be trying to correct the shift of the Mackenzie maneuver. And if that fails, then do the rotation manipulation that you were shown on the first module. Failing that, get somebody else to do this for you, do a traction on it and see what happens. I think when you see a Mackenzie shift, not the maneuver now, the shift itself, these are readily identifiable, but it's just jutting off to one side, and they're almost always accompanied by severe back pain, so much so that people mistake these for disc herniations. And this takes a lot longer. You have to pull over much more carefully and so on. A disc herniation can do very similar things. I usually reflect kyphosis involved in that as well. But if you try and pull that over, both of you are likely to end up on the floor. So I think this we're talking about now is a much milder version of the Mackenzie shift. So I promised you that we would look at the anterior version of this. And again, I think it's just an anterior translation. So again, here's your vertebra as they should be sitting. Now this, I've never seen this in the lumbar spine, but it does occur with fairly frequent frequency in the thoracic spine. Never seen it in the lumbar spine. It doesn't mean to say it can't happen, but I've never seen it. So this is the way it should be sitting, and what you see now is this. It sits like that. And occasionally you can see this on x-rays. The closest you can come to it is to think of it as a spondylolisthesis. So obviously, the facet joints are having to overflex, and it can't be doing them any good. But this, again, isn't a bilateral flexion subluxation, although it's often modeled that way. The problem is, if you try and treat it like one, is actually a very springy endfield when you just bounce off it. Now, these can be extremely painful. Let me see if I can just take off this bit here. Yeah, these can be extremely painful, or they may be asymptomatic. But I actually treated one of these in the intensive care unit. He was admitted for a heart attack, basically. They ran all the tests and it was all negative. Then they asked PT to have a look at his back. And this is what I think I found. Anyway, I manipulated him in the ICU and his pain went away. So they can be that severe or they can be completely asymptomatic. But essentially, diagnosing this is not easy because there's no asymmetry. So when they bend forward, these don't rotate. So you can't use position testing on these. So you're going to have to do one of a couple of things. If this is asymptomatic, you're going to have to go through those classical flexion extensions, side bend and rotation mobility tests that you know and love so well. And you should be able to pick it up there because this thing won't be able to flex. It won't be able to side bend probably or rotate very well, but it might well be able to extend. Sorry, I'll be able to flex, but not extend. But if it's painful, it's much easier. If I do a PA on this one, then first off, the endfield is going to not be hard or jammed. But if it's painful, that's when they're going to get the pain. It's going to be painful plus whatever the pain level is. But if I do a PA on this one, it's going to be less painful, but the endfield is much more solid. Treatment for this, same thing, traction and let drop, or drop and let traction. But in the thorax, you can do this. In the lumbar spine, again, you're going to have problems. As I say, I've never seen this in the lumbar spine. So I hope that clarifies this a bit for you. There's no reason why we can't discuss this more on subsequent Zoom meetings. And look for them. Lumbar spine, the translatory ones are not rare. They're not as common as the facets. In the thoracic, upper thoracic spine, I'd say that these anterior subluxations and transverse subluxations together are probably more common than thoracic facet joint problems. But that's me. You need to make up your own mind, and what you see is what you've got. Okay? All right, guys. Talk to you in a bit. Bye.